Great. I'm going to talk about health policy and budget policy, or health policy is budget policy, and budget policy is health policy. This is sort of the agenda, the issues I want to go over, and then how and why healthcare is changing, which is partly why making those projections is so difficult. And then this gets at the question we asked before, the issue, shifting in payments and shifting in healthcare, shifting from activity-based payments to value, quality, and outcomes. So the old paradigm was fee-for-service to performance-based stuff. There's a lot of ways to talk about it. We'll talk more about it. And then also the insurance market delivery system changes. And also I'm going to talk about multi-payer alignment. And what I talk about, because I really see it as a huge sea change or landscape shift, Medicare, HHS, is operating in a really different mode since 2008, 2010 than it's operated in the last 20 years that I've seen. A lot more of this, they want to be in alignment with not only Medicaid, which is kind of it's a government program for the states, but with private payers as well. They want to be in alignment because they realize the more dollars that are all pointing in the same direction, the more rules that are all the same for the hospitals, doctors, and everybody else, the bigger impact that they're going to get. So that what I call multi-payer alignment is big. And also in terms of getting data and sharing data, Medicare and HHS is dramatically different. It used to be Medicare would put out its rates and let the world respond. They would tell people the only people going to have data are a limited number of uber academic analysts. They have this 5% sample and that's it. Now they're giving data to health systems that are going at risk and all sorts of people. It's not like individual patient information, but they're given that data. Who asked about how healthcare is changing? Is that you? Okay. We're doing okay-ish on time? All right. I've alluded to this a few times, that healthcare is changing information, paying for outcomes like Medicare, instead of just paying for activities, paying for services. Medicare's actually set a goal for what they're calling value-based payments. So instead of paying for a service, like you get your knee replaced, you get a doctor's visit, a checkup, you go in for chest pain, they want it to be more bundled, more like the person got better, as opposed to just you saw him, he did something, whatever. They want that to be 50% by 2018, 80% by 2020. They're calling this, the new term, the terminology of this has changed all over the place the last 10, 15 years. Alternative payment models. There's already shared savings ACO, a lot of it's in bundled payments. There's generally a continuum of all these reports, going from pay for reporting to pay for performance to shared risk, shared savings and then shared risk, to partial capitation or bundle payments to full capitation. Basically, how much risk you're assuming, what you have to do to get some extra kind of payment. They're already doing all sorts of things. This has gone on for a number of years. Not paying for preventable events or errors. If you have, it started with heart attack, myocardial infarction, congestive heart failure, and I think COPD, lung disease, chronic obstructive pulmonary disease. If you were Medicare and got discharged from the hospital and you came back within 30 days to a hospital, Medicare wasn't going to pay you a second hospitalization fee, because their attitude was that shouldn't happen. You should make the hospital have incentive to keep people out of the hospital. Before this went in a few years ago, the hospitals, see you later, and if you bounced back, the hospital got paid again. They really didn't care. Now they had incentive to try and make sure that you got those kind of services, you stayed out of the hospital. They've since expanded it beyond those original 3 services. And private insurers have done the same thing. There's also, they've got a new physician payment system that's going to kick in a few years that's going to be tied to quality. Part C, I think of this as value-based payment. I have disagreements with people. Basically, the managed care plans, they're getting a capitated dollar amount, so they're responsible. They're at risk for that whole thing. If they spend a lot more over their capitated amount, they're at risk for losing money. So I think of that in some ways as value-based payment. And again, aligning with the private payers. Because what people have come to realize, and it's not, I think it's long overdue, but that if you're a hospital or a doctor, you're not going to change what you do. You're not going to change everything you do when somebody's saying 20% of your dollars are at risk. Or if you're a hospital, 50% for Medicare. It's got to get up to 60, 70, 80% before you say, hey, that other 20% I can not stop worrying about. I'm really going to change my operations. And some leading health systems in the country, this is the way they're thinking now. They realize we can do better financially by taking better care of patients. The incentives are aligned in a different direction. And also simplify the providers when all the private payers are aligned, or enough of the private payers are aligned with Medicare and Medicaid. Some of the innovation centers, there's one particular called the CPCI, Comprehensive Primary Care Initiative, where they basically put out to bid Medicare dollars against state Medicaid dollars, and any private payers. And they said, whoever comes up with the most dollars for the most people in a geographic area, we're going to align with. And they've gotten 7 geographic regions, a couple of them are whole states, where they put it for improving or changing how they're going to pay primary care doctors, paying them more and paying them differently. Barry didn't want to show this slide, but I felt I had to. These are the original 4 things here, but I've added sort of social services because what people come to realize, as I've alluded to, those sick people who may go home and not take care of themselves doesn't fall into really normal delivery, research, finance. It really gets into social services and overall community health. And that's really what people are recognizing is driving change in healthcare spending, maybe an opportunity to bend the cost curve. This is a chart that Elizabeth Bradley published a few years ago. These blue bars are OECD data on healthcare spending. And this is the United States right here. You can see this is the blue bar up here. What she did was she looked at that same OECD data set, but she added social services spending, which is these red bars. You stack the two together, and the United States comes out right about the middle, which is kind of where our outcomes are. This makes the point, people talk about the social determinants of health, sort of healthcare, what goes on in a community, unemployment benefits, housing, food, all sorts of other things that really contribute to the health of people, not just healthcare services. She's trying to explain why that is, why we spend so much on healthcare, but the health of our population is so poor. Her thesis is because we spend so little on social services, those social determinants of health that really impact what's going on. There's a guy, Jeff Brenner in New Jersey, who's won a MacArthur Fellowship, who's done a lot of this. Tulwani wrote about it, called Hotspotters, finding those really sick people who really need social services. It comes back to that 5% who are costing 50% of health spending. It's like that other pie chart with the hospitals. If you want to go after the money, save money, where do you go? You don't go to the triathletes, right? Which is what that whole value-based, outcomes-oriented change we're going through. Which is one reason I think we're beginning to see a shift in the cost curve. And for any of you guys who are really interested, stay tuned. Elizabeth Bradley is doing a study, I think it's going to come out next month, doing the same kind of analysis, but all U.S. states, their health spending and social service spending. And I am, having looked at some of these data and knowing what's going on without the data set she's looking at, it's going to come out looking a lot like that Medicaid FMAP map. The poor, mostly southern states don't spend on healthcare, don't spend on social services, and they have really poor outcomes. High obesity, high diabetes, high cardiovascular, low life expectancy. Again, correlation doesn't prove causation. We can only work with the data we have to figure out how to change programs and model. This is how I conceptualize it. It's all about transparency and accountability. The value-based, outcome-based payments are holding people accountable for what they're doing, right? You're paying them based upon the outcomes that they're getting, and you're holding them accountable for that, both dollars and clinical outcomes, the health of the patients, health of the populations they're responsible for. But you can't hold somebody accountable without data. And you can't hold somebody accountable for how they did 3 years ago. What's happened in the last 5, 10 years is data systems, IT systems have advanced. And I'm not going to put all my faith in computers, but really it's the reality. We now can have data soon enough, that's valid enough, that's reliable enough in a near real-time way. And by that, in a lot of cases, it's within a month, within 6 months, that doctors and hospitals can get that information and be held accountable for what's going on, how they're performing. When somebody's going to be held accountable by whoever's going to pay them, the extent to which they're going to use the data and the data is going to influence how much they're going to get paid or be at risk for losing money, they both have to recognize that the data is not perfect and they agree that it's good enough. And that somebody pointed this out to me. How do you know when the data is good enough? When everybody's sitting around at the table that's got to rely on it and is going to be held accountable for either paying or being at risk for getting paid or not getting paid, they all agree it's good enough. And they all recognize the data is going to keep getting better. So if the data is limited, it's maybe a little fuzzy, you're not going to put a huge percentage of your dollars on the line. But it's a place to start, and it's going to be moving forward. Because of better data, you can evaluate programs a lot faster. And it can be built, real-time evaluation can be built into program management. It used to be like in the 90s, early 2000s, the effectiveness of like a maternal child health program was how many women got served. How many women got better prenatal care or got prenatal care at all? That was the metric for, was our program working? That's kind of the equivalent of fee for service. Now they're working into programs, we're doing X, was it effective? Did the rate of low birth weight or premature infants go down? That's an outcome, that's a real outcome. That's not how many women did we serve. And the incentive that shift creates is not just serve any woman we can find, because they're the ones you can find easiest are probably not the ones who need it the most, but where are there pockets of bad outcomes, of low birth weight, of premature delivery? That's where we're going to go target the resources to get better prenatal care. And then you see, did we improve the rates for the condition we're trying to fix? And you can do that with better IT systems because it's on computers. It used to be you had to go sift through charts. And then this is something we talked about. Healthcare is different than health insurance, is different than health. So the individual level, the community level, and the social factors. The other term for this is social determinants of health. What are those determinants in the community that determine health that are social? The ACA is bringing on many changes after 16. And again, this is a thing that's going to happen in November that's going to be important. And if it's anybody's guess what's going to happen. So thank you for listening. Now it's your time to ask more questions because you didn't ask enough. You're being graded on the number of questions you asked. He didn't tell you that, did he? So, yes.
Do you think Obamacare was effective?
Absolutely.
You think it's better than not?
Absolutely. Absolutely. Clearly, Medicaid expansions helped millions of people get insurance. The insurance rules changing, creating a sort of baseline for the country, had dramatic effects. Made people like me, when I was working myself, able to get insurance. I was living in Massachusetts. If not for Obamacare, I would have had to go back to Romney Care to get insurance in Massachusetts, because here in Virginia or DC, the rules, they could have just said you can't have insurance. I will say the 3-to-1 age ratio was very aggressive. I was talking to Barry about this. In Massachusetts, I think it was 4 or 5-to-1. There was no state that was aggressive as 3-to-1. That was one of the things that probably would have gotten stretched out in conference. The Innovation Center, the $10 billion over 10 years, that probably would have gotten cut back. I actually think that's been a very good investment. Not everything has worked because they're trying a lot of new things. Probably getting some criticism. The prevention fund already got whacked back a lot. The CLASS Act, the long-term care thing, never happened because I think it was Senator Harkin's thing, and I think a lot of staff knew it wasn't structured a way to be fiscally stable. It hasn't been perfect. No, a lot of it's, and healthcare.gov as a technological thing was a mess, but that got taken care of. But overall, it's created an insurance structure framework for the country to move forward with. Because part of the problem pre-ACA was every state had its own crazy insurance rules that was really a problem. And one of the things the ACA did was it prevented insurance companies from underwriting, denying insurance based on pre-existing conditions. So it's eliminated a lot of that ability to completely avoid risk. One of the problems in the marketplaces, which is going to be interesting how it plays in the next few years, a lot of the younger, healthier people aren't signing up for insurance. That's part of the reason why there's been bigger losses than expected. It was expected a lot of people were going to buy insurance who didn't have it, who were young and healthy. Well, they're actually trying to create incentives for insurance companies to take those sick people and make them healthier and save money. We got to go. We're going to stop.
We can keep going.
I'm trying to get it so you guys don't have to write that thing at the end of class. But thank you very much. And I'll get these slides, Barry, to get to you. And if you have any questions.
Mike, we have one more thing for you.
Okay.
A slight remembrance for putting all this together.
It's been my pleasure.
So the school got renamed. So I know you haven't know, but this is the school with a much longer name.
School Policy, Government, and International Affairs.
Right, so it's you couple and small,
Oh,
and a couple on us.
thank you very much, Fred. Thank you, Bob.